Sure.
Yeah. So we went ahead and made the referrals to radiation oncology and hematology oncology yesterday, as soon as we got out of the OR. So those consults, because basically your fund source is through the TLC clinic, those consults have gone out already, and the reports that I dictated yesterday will accompany those consults. The only thing that's missing is that written path report, which will probably come out in the next day or so. But the pathologist called me straight away and told me that all the features that were there to make the diagnosis, they felt confident to make the diagnosis, so they told me.
Okay.
I said before that sometimes they hedge, and if they did, I wouldn't say anything, but there was no hedging.
Doubt.
Yeah, they basically said this is, and when you look at this up close, you can tell that it's very disorganized, very angry, very...
Okay, where was it before? Do you have pictures of that from when you first seen him?
The very first one?
The very first shot we did here, but the quality of the photo...
Sucked.
Yeah, was nowhere near...
Yeah, you can't even really see it.
Yeah, that's not really good.
Yeah, and I wasn't able to see down that tube.
Yeah. So, this morning's event, what's happening today? At 24 hours, you're at maximal swelling from any procedure. So, by manipulating the tube or a tumor, we gave you steroids in the operating room. But those would have worn off by last night. And so basically, if there was any swelling that resulted after the steroids have worn off, that would be something that you would feel in the way of restriction in breathing, maybe a little bit of noisy breathing. And if you coughed, you would probably bring...
Some of this off?
Yeah, you would bring these two structures together and then jet air past it, which is going to make... This is probably not bright red right now, it's probably dark brown with the scab.
Okay.
But if you rip off any of those superficial scabs, you'll get some blood. Okay.
So that is normal?
That's normal.
Okay.
That's normal. And you may see more of that in some form or fashion during radiation treatment. But with radiation and the sort of the killing off of the tumor, you end up eliminating the growth of the tumor. You slow it, you shrink it, it goes back to being more of a smooth surface. It doesn't bleed at that point.
Okay. Okay, so on the 23rd, do we come to you, or are we going to the oncologist himself?
Actually, I wrote 23rd on the paperwork thinking that was the clinic appointment for me set up at TLC. When I called the TLC, they said, no, actually, Dr. Johnson, you're going to be here on the 3rd. It doesn't matter. Dr. Treadway, the radiation oncologist, and the hematology oncologist doctors, we want them to see you ASAP, get you started with treatment, and then I'll see you whenever you need to be seen, but the appointment that's available for me to see you there, the next time I'll be in that building is apparently October 30th, not the 23rd, so it's the very last Tuesday of the month, not the 4th Tuesday of the month.
Okay, so we're not going in on the 23rd either then?
No. I wrote that on the paperwork at UMC Hospital,
right.
But they have no way of verifying that, so that appointment is actually the 30th. And Grace will be contacting you.
She gave us the 30th.
Good. Good. So that takes
okay, and that's when we're going to see the oncologist for the first time?
No, you should see him before then, I hope, unless Dr. Treadway can only be seen or can only see you at that time.
Dr. Treadway.
Yeah, Treadway is the radiation oncologist. 21st Century Oncology is the radiation oncology group.
Okay.
Dr. Treadway is the doctor who basically, who is the one we've asked to take on David's case.
Okay.
As I mentioned to...
So he should be getting a hold of us for an appointment.
Actually, Grace should be coordinating it, because I imagine that...
I tried to get a hold of her all morning this morning about the... Oh my God, it's impossible.
Yeah, I should have given you my card again and told you just call me. Grace is very instrumental in getting approval for hospitalization at UMC. She's got a record for David at the TLC clinic. All of the funding for David's care is coming through the TLC clinic. However, I saw you here first. I have a chart here as well.
Right.
So these pictures will be a part of this chart here, and this is a way for me to communicate and have records available when I'm not at that clinic, because I'm only there one day a month.
Okay.
So if he's gonna call us, they would want to make sure he doesn't have to set up an appointment or anything.
No, you don't have to go after him. They will come after you through Grace. And I'll check with Grace later today to find out what point we expect Dr. Treadway to see you. Dr. Treadway comes to the TLC clinic anyway, but he comes once a month to see new cancer patients. That's already happened for the month of October. Okay. But it doesn't mean that he can't see you out of cycle. It just means that we would rather have you seen, get, essentially started ASAP, and then subsequent visits might be at the TLC clinic. And you may meet Robert Wong, my boss, the head and neck oncology chairman of our department, who may actually see you back. Or because a lot of times this becomes a very focused radiation treatment goes very well, you may not you may only see me and Dr. Treadway. And then at the end of the treatment, we tend to do a PET scan or a CAT scan to measure everything. We're going to do one ahead of time as well. Again, you'll probably get that referral from Grace and Dr. Treadway. And then we do a comparison of where the tumor was, what the tumor looks like, and then you have a requirement to see us on a regular basis for about 5 years.
How long is the process of radiation?
Typically, it's like between 4 and 6 weeks. And it depends on how they...
Once a day?
Once a day, yeah. It depends on how they typically do a calculation of how much tumor is there in volume, and then they formulate exactly the total dose, and then they divide that dose out as to how many different days. So it's a recipe based on different things. I've not actually been a part of that or seen that process since residency, so this is how I observed it being done by radiation oncologists when I did my rotation in the late 1990s. But today it's more computerized. The radiation dose is given in a way that spares some of the tissue from excess injury to the skin and such. For the most part, as long as we don't get swelling of the tumor that causes you difficulty, we can avoid the necessity to putting in a trach, which keeps you from having all of the wound care associated with the trach care.
Is there any long-term effects of radiation?
Because it's so focal, it's pretty much limited to this area. So yes, you could have a dry throat. You could have some need for thyroid hormone replacement. Okay. There may be a change in the voice quality as a result. And we have to be mindful that we expect radiation to work because it works 85–95% of the time. But if it didn't, then there may be a need for surgery afterwards. So those are all potential factors. But I'm hopeful that we're early, it's small, you're young. We're going to get on it right away.
So it is smaller.
Yeah.
Okay. Chemo.
Chemo is done to make the tumor more sensitive, but that's a judgment call of the chemo doctors, and what they're trying to do is make the radiation more destructive of the tumor. And so sometimes they will recommend giving several doses or 1 or 2 doses of chemo before radiation, or sometimes in the middle of radiation. But this is not a tumor that's principally treated with chemo alone. So chemo is an adjunct or an add-on therapy to make the radiation therapy better. I don't know whether they will make that recommendation. Between Dr. Treadway and the chemo doctor, they may go, we don't want to do that. What we want to do is go straight radiation therapy. And that would be their expert opinion, which you accept or reject. It's kind of hard to imagine a scenario where a chemo doctor says, no, I don't think you should get chemo, and the patient says, no, I think I should. I mean, that's kind of a bizarre scenario. It's a possibility with the internet and people reading things. You may make that judgment. But most patients end up seeking another opinion from another physician who has made that recommendation, and so you're choosing between 2 opinions.
Right.
There is a second opinion built into our work up here, because we're working kind of quickly. But if you met with Dr. Treadway or the oncologist, and you said to yourself, I want to hear it from someone else before you, Grace and I would be responsible for trying to get another person's opinion in so that you could have, you know, a choice and not just a single choice. So those are things that can come about, but not as often for this, because when you, I think, look at the internet, and I can give you some sites to look at, it's pretty uniform. Other areas are kind of vague and sometimes confusing, but this one's pretty straightforward.
Okay, so how far has it gone from the first time you seen him until now? Because you said it spread rapidly.
I think it's growing rapidly. When I first saw
growing rapidly.
Yeah, when I said it was, yeah. These tend not to spread to the rest of the body. They tend to stay in one area for a while. Right here. When I first saw him, it only took up maybe a third of the view.
Okay.
Now it's taking up. Yeah, you can't see the cord at all. It goes. So if the epicenter is here, and it's been growing like this, and it just pooched through there, then still a T1 tumor. But
okay, so you're saying that up in here,
right,
the epicenter is where you cannot see it. It's like an earthquake.
Right, we're looking at the
That's
surface
underneath the
of it.
skin.
Right, we're looking at the surface of it. Right, right. And that's the only way I can explain. Now, sometimes these will start superficially, and they'll just go this way and that way. They'll start across the surface. But just by touching it, looking at it, grasping it, I believe that it's not one of those superficial ones.
It's up underneath someplace.
I believe it's within the substance of the cord itself, and that's why we're seeing more of its overall body in the OR up close in high def than what we saw when we looked at it through the flexible scope here in the office on the 26th of September, I think it was. Yeah, so 19th September.
Okay, she was saying that it was also growing down his throat. Is it?
It is not going down. Okay, when you say throat, typically you're talking esophagus. Okay, the food pipe.
Okay, where is the?
Behind the windpipe. The windpipe's up front.
Okay, where's the vocal cords at?
The vocal cord is right there.
Okay, so is it coming down this way?
No, it is not this level. It is here. So it's full body vocal cord.
Okay.
Okay. So
it's not technically throat cancer, it's vocal cord cancer.
people use them interchangeably, but a tumor on the tongue can be called, in layman's terms, a throat cancer.
Oh.
A tumor anywhere in this picture could be called a throat cancer, a sinus cancer, But most of the time when people think of throat, they think of the
down inside the throat, right?
The food to go to your stomach.
Exactly.
And that is close enough to this area to be considered, a valid way to describe it. But when we talk doctor to doctor, when I'm talking to Dr. Treadway, I'm going to say larynx. I'm going to say voice box, larynx, which is the medical term for voice box, laryngeal carcinoma. And the pathologist has told me it's a squamous cell, which is 80 to 90% of all cancers.
Say that one more time.
Squamous cell. Squamous is the tissue that lines our surfaces.
Okay.
So a surface tumor leading into the deeper structures, most likely.
Okay.
So that pretty much defines the term or the tumor for us, and that pretty much drives how we pretty much treat it. Okay. So what is it like during treatment? Mouth is very dry, can be difficult to swallow sometimes. Sometimes